I think we might make a start. My name is Jenny Phillip, and it's my honour to welcome you to this afternoon's presentation and Perspectives event. I am very proud to be hosting this event on behalf of the Palliative Nexus Research Group, who've been running these events sort of off and on, well, mostly on, since 2020 when we first went into lockdown in Melbourne. And you'll remember this is a way that we conceptualised for us in the palliative care community to come together, hear from each other, hear updates of the latest events, and also to, I guess, continue to learn as a community. Before we begin today, I would like to acknowledge the traditional custodians of the land. I'm on the land of the Wurundjeri people of the Kulin Nations, and I wish to pay my respects to elders past and present. And I also wish to pay my respects and acknowledgement to any Aboriginal and Torres Strait Islander people who might be in the audience. Today we are fortunate to be having a Perspectives research event. And as you know, our research events or updates are where we have the opportunity to hear from people from around the world, including great leaders in our own backyard. And that's what we have the privilege of having this afternoon. And it's my pleasure to welcome Professor Philip Good. Philip's a palliative care specialist who works in clinical practice at St Vincent's Private Hospital in Brisbane and the Mater Hospital in Brisbane, and he's also a professor at the University of Queensland. He has a particular interest in research involving palliative care patient experiences and their carers' experiences, and also palliative care for people from culturally and linguistically diverse communities. And also he's been involved in clinical trials, and I guess it's in that realm where I first have come across and enjoyed working with Philip over the years. He received specialist training across Australia and then spent several years in Newcastle before returning to Brisbane. During his time in Newcastle, he completed a PhD on evidence-based palliative care at the University of Newcastle. And now as a clinician researcher, he combines clinical practice in palliative care with research aimed at improving patient outcomes, seeking to ensure that his patients have the highest quality of life possible for as long as possible. This afternoon, Philip's going to talk to us about how models of care influence patient outcomes. So welcome, Philip, and thank you.
Thanks very much, Jenny. I just wanted to acknowledge traditional owners as well. I'm on the land of the Turrbal people. So this afternoon, I was going to talk about how different models of community specialist palliative care influence patient outcome. And I think the title is slightly different to start with. But in Brisbane, over a period of time with St Vincent's, really, we've been involved in looking at different models of community specialist palliative care. And they've really come about because of funding and how funding has come up differently in different areas. So it starts with really a traditional approach to funding, which was very much done from a Queensland Health publicly funded service and has expanded into funding from private insurers in the community. And within that, surreptitiously, they've actually done it via different models, and that's enabled us to maybe have a look at what does that mean in terms of outcome measures from that point of view. And one of the things I'll try and do as I go along here is just look at how things have changed. So this is a very old painting, oldish painting of a view of people dying at home. And interestingly, I'll show you how that's transformed. So this is something that we see a lot, this idea that, you know, there's a sort of famous Grattan Institute report came out and said that 70% of Australians want to die at home. And it's pretty much quoted ad nauseum if you're involved in literature around that. And part of this research, interesting, is when you ask people on a palliative care program how many people want to die at home, and it's slightly different. Does anyone, I quite like the interaction if people can put in, I don't know if they can put in things, but does anyone hazard a guess, if they haven't read any stuff we've written, of what % of palliative care patients actually want to die at home? Anyone want to put a guess in there yet?
10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10%. 10
Jenny's put 30%. Anyone else want to hazard a guess? So that's one of the questions we'll answer as we go along, about how many, and it's really interesting because it varies. Anyway, there's another one here. It's a bit older. It's looking at where people die around the world, and it shows that some countries are much higher than other countries, as it turns out. And there's this idea: evidence supports access to home palliative care increases the chance of dying at home and reduces symptom burden without impacting on care or grief. And you may think that there's a lot of evidence for that, but in fact, there's not that very much evidence for it as such. So one of the things, certainly my trainees do better than me, but they use ChatGPT. But there's actually a version of ChatGPT which is essentially makes drawings for you, and so you can just type in draw a modern picture of dying at home, and this is what this came up with. It's called DALL-E, so that's what this came up with. So interestingly, this is the perspective of percent of people who die at home. This again is a little bit older, but looking at a review, they looked at around the world, how many percent of people die at home. And as you can see, it varies. So some of the Australian ones, which are lower here, are 18%, 20% from a while ago. And often we think that we do a much better job, but it's interesting that in reality, about probably somewhere between 20 to 30% is the figure of how many people die at home in a palliative care service in general, and it hasn't actually changed a lot over a long period of time, despite trying a lot of different things. So, sorry, before I go back to that, so the next question I wanted to ask was, in terms of your own palliative care service, I really have, there's three interesting questions about this. In terms of your own palliative care service, what do you think your home death rate is on your own palliative care service? And what do you think the highest published home death rate is on any Australian palliative care service? I'll give people just a few minutes to put in some bids around that. And there's no right or wrong answer. Like, what do you think in your own palliative care service? What is the home death rate? Anyone happy to put something in? Okay, sorry, this is different. So 40 to 50% in the community service in Melbourne, that's good. Just to say, wait. So I think it's in the Q&A, people are putting this in. So 70% is another one. Anyone else want to put in what they think the highest published home death rate is in Australia? Anyway, I'll just bet, but I don't know if people are interested in this area. There's a very famous, I shouldn't say famous, but there was an inquiry in the Senate into palliative care at one stage federally, and Silverchain in Western Australia at that inquiry said that they had a 75% home death rate in a Senate inquiry. Interestingly, if you actually look at the published literature, and this is what this is Silverchain in Western Australia. It doesn't say that, but they looked at they were looking at the impact of community palliative care, and it turns out that the highest published so far home death rate, which is out of hospital, is 49.1% of people on the palliative care service in Australia. Now there may be other ones published which I'm not aware of, but a lot of services think they have a very high home death rate, but when you actually research it, it's actually much lower than you think. Anyway, one of the things about community palliative care services, specialist community palliative care services, is that it's pretty much done differently everywhere, and everyone's got a different model. And as I was doing this talk, I often wonder about what an actual model is, and I find that really hard to conceptualize what a model means. Like, often when I'm involved in negotiations with private health funds to get a new service on board or other people, they say, "What's your model?" And it's like, I just think, well, the model is you go and you have a multidisciplinary team, and you go and be involved with a patient, and you have after hours involvement with the patient, and you have on call, and that's the model. But it seems like everyone's sort of got a slightly different model. And one of the things in the past was people looked at what are the common practice themes, and they talk about this is from Canada, and they look at specialized expertise, communication, timeliness, symptom control, advocates. So there's a whole lot of things about what does a model look like. So this is where I work. This is St Vincent's private hospital, Brisbane. That's called private hospital. It's actually got palliative care, public and private contracts. And that's where the inpatient unit is on the 3rd floor. And we actually have 40 beds. And this is where the community service goes. So this is in Brisbane. Brisbane, as most people know, is divided pretty much by a river, north and south. We go across the river, not many services do. And our area traditionally is the Brisbane City Council area, which is outlined in red here. And it's about 20 kilometres from the city, and we pretty much where the B is where, or maybe the bottom of the A is where St Vincent's is in Brisbane. And this is the suburbs, and as you can see a bit, there's a concentration around the city. All these little stickers are a bit where the case management of patients, and this is how this service works in a case management model through that. But as you can see, it's about 25 kilometres in each direction. So just to look at the outcome measures. So we've had this public or Queensland Health funded program for a long time. And then we, 7 years ago, in fact, we developed a program that was funded by Bupa. And then about 2 years ago, but actually 2.5 to 3 years ago, we developed a program by Medibank. And they've actually all got different funding models, which enabled us to look at outcome measures. And then we actually got 5-year data for Bupa, so long-term data. So model, I find models very hard, and this is what we have as our model, which doesn't mean that much because everyone's the same. You get a patient referred to you, you get an assessment by someone, a doctor or a nurse generally, all combined. And then depending on how things go with the patient, you look at patient choices of care, choices, preferences. Do they end up in an inpatient palliative care unit? Do they stay at home? Do they get discharged from the service as well? And I guess if you wanted to look at what our ethos is a comprehensive support 24 hours, 7 days a week for patients, their families and carers, including domiciliary nursing and allied health services. So we actually don't provide full domiciliary nursing in the sense that we don't provide people who come out and wash the patient. That is done by a domiciliary nursing service. We do provide allied health services. These are all available to visit at home. We provide an after hours service, so on call 24 hours a day, 7 days a week. The nurses visit after hours as well from that point of view. We also have an inpatient unit, which people can come into directly without actually going through an emergency department, and that's available for admission 24 hours, 7 days a week as well. And that's pretty important. And then we have this sort of intensive specialist palliative care, which is extra support in the last few days of life, which in reality is using an assistant in nursing available in shifts. I'm going to talk about that. So this is sort of the program. And one of the hard things about all this is to say, what is the difference between a Queensland Health publicly funded model versus a Bupa private insurance funded fee-for-service model versus a Medibank capitation model? Yeah, we'll talk about, we can talk about discharges because actually it's listed out there how many people get discharged as you go along from that point of view. And one of the reasons why people get discharged is because, well, there's various reasons which we can talk about. But so in our team, there's all this team. The interesting thing when this all started was that in the Queensland Health public model, we call it, there was some things not available that were in the Bupa model. And then as time went on, they became more available because we found they're beneficial. And then there was certain different things done in the Medibank model because it was a capitation model, which we can talk about. So just in general, it's not all the things. So who could go onto the Bupa community private insurance model? It's called choices model. So this is where patient has Bupa hospital insurance. So any type of Bupa hospital insurance, prognosis less than 12 months, a clear diagnosis and terminal prognosis. There's no cost to the patient and it's case managed by a nurse generally. And the next one is Medibank, which was selected patients who have Medibank hospital insurance. So slightly different. Bupa, for example, they were very broad. So if you had Bupa overseas insurance, that was fine. Medibank, it wasn't fine, for example. And the Medibank program was really much about people had to express a desired wish for end-of-life care at home. They had to have a clear diagnosis and terminal prognosis. Again, no cost to the patient, and again, case managed. So just an answer to your question about allied health disciplines in the community, depending on the program, technically we have most allied health divisions. So we've got, I can't remember if I entered that actually before, maybe I did. So physiotherapy, occupational therapy, counselling and pastoral care would be the basis of it. Technically on the private programs, you probably could get speech therapy if you wanted to. We don't do much. And dietitian if you wanted to. We don't do much of that as such from that point of view. And then the public program, you have to have advanced progressive disease based on symptom needs, no cost to the patient again, case managed, but probably a lower ratio in the sense that each nurse had more patients per nurse probably than the private model. And when I talk about, as you'll see these results, when I talk about standard cohort, which this group makes up, is it was really trying to get the next person admitted to the public program at the same time as someone admitted to the private program to try and get a comparison between the two. And as you'll see that they change over time. So this is, again, a modernist approach of asking the AI to draw a picture of a monk version of a modern approach of dying at home. And as you can see, it's a bit scarier than the old one. So funding is interesting. Bupa has a fee-for-service model. So similar to what you would consider like a traditional private model where you only get paid for things you do. So each visit you get paid. There's no payment. There's no payment for after hours on call, be on call for after hours, because that was broad in the whole program. Medibank had a capitation model. So that meant that you got a set amount from the time the patient was admitted to the time they died or discharged. And there was actually a penalty for admission to a St Vincent's Health Australia facility, which is only St Vincent's Brisbane or St Vincent's Northside, small penalty from that point of view. And you couldn't lose money in the sense that the maximum penalty would be half the overall fee, which no one ever got to because the penalty wasn't that big. And the public program is similar to what a lot of people are paid for in a public contract program, is you get a broad set amount and you have these broad targets around occasions of service as such. And so technically there's no fixed numbers. Like we don't cap our numbers as such. We just take on board whoever we get referred for all of these programs. So there's no capping as such. So anyway, the first year of Bupa, we published this article about supporting choice. And this is some of the results we'll go through around this. So just if you look at a couple of things as we go through, these are the patient characteristics. And you can see some differences in all of this. So the obviously they're not exactly matched. That's the first thing, that they're closely matched, but not exactly matched in numbers. But in things like days on service, so the time from they're admitted to the time they get discharged, which is usually death, but not always, there's about 45 or 46 days, which is really interesting. It hasn't changed that much. And I was just talking to someone else recently about how when I was a trainee, I did a study in Newcastle where I worked, and I looked at what was your time from admission to discharge. And I think I had it was about 43 days, discharge being death or dying or discharge from the service, usually dying. It was about 43 days. That was a while ago. And at the time, it was one of the longest length of stays on a palliative care service there was, because it was often in the context of a lot of American studies that actually showed that the time on a palliative care service was somewhere in the realm of 20 days. Mostly patients with malignancy, and mostly, interesting about this. So 60% of people died in this. So people came on, and this is in the first year, and 60% of people died. And as you can see, there's a little bit of a different discharge rate. So 14% on the Bupa cohort and 10% on the standard cohort. Now, the reason for discharge, it's sort of, you can read the article, but it varies. So sometimes it's because the patient moves out of the area. Sometimes it's because the patient stabilizes and no longer needs palliative care input as such. And probably, and sometimes they decide they don't want palliative care anymore. And sometimes they, most reasons is because they are stable. And sometimes they just move somewhere else as such. So that there's a certain percentage of that. We don't really have a standard cohort. We don't really have in terms of discharge, we don't. Oh, sorry. And coming onto the standard cohort, we don't actually have like a prognostic part of that. So no, it's not really prognosis driven. It's more needs driven if they've got advanced disease. So it's not like you have to be in the last 3 months of life or 6 months or 12 months. So we do get some people who are quite long stayers. So this is the Medibank data. So a couple of things about this is that the Medibank data, the Medibank program is very much about an end-of-life care program. And so it's slightly different in the sense that the age is pretty similar. You could probably see the numbers are lower. So 67 patients only in the first year versus if I go back to the Bupa one, there was 130. But just also note 77 died on the Bupa program, and we can look at 67 on the Medibank program. Similar cohort in general. Interesting, the standard cohort just happened to have more malignancy than the Medibank cohort. There wasn't anything about that necessarily. A few more people died alone on the Medibank cohort from that point of view. So just going through this one about, again, looking at your preferred actual place of death. So this is where I found it starts really interesting. The Bupa program was done 7 years ago now, the first year, but very few people have actually looked at what is your preferred place of death in a palliative care program. So I was really interested in this idea. So the first thing that came up was, the Bupa cohort, they had a 53% preferred place of death at home. The standard cohort had a 31% preferred place of death at home, which I thought was really interesting. That just choosing people. So these are just people, one program, the next program coming up, you can see such a stark difference. Now, part of the Bupa cohort program was to try and give people choice. So if they wanted to die at home, it was a choice to die at home. And one of the things we can talk about slightly at the end is this whole idea of preferred place of death, which is really a challenging concept, I think, of patients versus carers. And then the actual place of death, so 45.5% in the first year, which we thought was really fantastic, which I think it is, to be honest. And the standard cohort was 25%, which is probably a bit low and a bit lower than you'd like. But, in the end, what it reflects is what the patient's preferred place of death is as such. And then, so interestingly, you go into the Medibank one as such. And as you can see, first of all, most people died, and that's what you expect, because people actually go into the program with the idea of being near the end of life and wanting to die. And they have this thing about what is the home death rate. So as you can see here, that 68% of people died at home, which is a very high number of people as such from that point of view. And a couple of reasons, like it says discharge, why people got discharged from the standard cohort, smaller numbers, moved out of the area was the main reason from that. So higher home death rate. And just looking at this this is just looking at the people who died. So and interestingly, so sort of, the preferred place of death home was 97%, which you might think is really high, but in fact, that's almost one of the criteria of coming on the studies. You had to want to be at home. Interesting at the same time, and so this is like 65 years later than the Bupa cohort, that pretty randomly, the way these people are generated, that there's 58% of people wanted to die at home, which is different. The numbers are obviously smaller, which is a marked difference to before. And then interestingly, that for me anyway, the home death rate here for the people who actually died, the home death rate was 80%, which is really good. The figure before is the number of people who died out of the whole total cohort. So it's not quite as high as it should be. And this is really just the people who died, not everyone. So people who died, so 80% of people died at home, which is a very high figure. And obviously we're trying to get this published at some stage. And the interesting thing for me is the standard cohort was a 43% home death rate, which is much higher than previously. And then you go into this whole achieved preferred place of death. And if we go back to the beginning with Bupa, it's very similar. You get this 80% people die in the preferred place of death, and everyone thinks that's fantastic. which it sort of is, but it really depends on what the patient's preferred place of death is in reality. So then, somewhat similar, just going back to the Bupa, I think I might have already done that table. So anyway, we'll go to the next one. So this is a 5-year data. So from that data, for the first year, you can see that if you choose a program where people are at the end of life and want to die at home, you get lower numbers, because in the background, about the same people have Bupa private insurance as do Medibank private insurance in Queensland or in Brisbane. So then we looked at like what's it been like over a 5-year period and how many people got admitted. So to the Bupa program, so there's no standard cohort with this because we stopped doing standard cohorts because it's pretty intensive after about 2 years of Bupa. So over this sort of 5-year period, there was a 779 admitted to the program. There's quite a few discharged at times and quite a few readmitted, and a lot died over this time, as you expect, and some were alive. So for a really larger cohort of patients, somewhat similar in terms of age, gender balance, pretty similar. About 12% live alone. Diagnosis malignancy about 80% or so. Most common is lung, and then length of stay is 47 days. So interestingly, over 5 years, the length of stay of that program for Bupa hasn't really changed between 43, 44, 44, 47, which is very similar at the end from that point of view. And again, you could say this is great, 85% or 86% achieved preferred place of death. How many people actually died at home? It turns out to be 42%, which is quite high for a long period of time. And it's really driven by the fact that 52% preferred home was the preferred place of death. So that sort of drives where you'd like to be at the end. And just briefly, I'm happy to go on to questions on this, just briefly, and then I'll answer some of the questions, sorry, as well, which I can see they're coming through slightly different places. But we did this thing called FamCare. I don't know if people know FamCare, but it's basically it's to do with the family, but it's also patient looking at care. What's their feedback? So it's really a patient satisfaction survey, which is done sort of continuously in the first 2 years and then cycles after that. From that point of view, and just to give an idea, it's really good if you ever want to do this because it gives you it makes your service look very good because most of the feedback's always positive. So anyway, we sent this to patients and carers, so patients during the time they're alive, to carers in bereavement, and the response rate's somewhere over 30% in this, which is pretty good. I think it's pretty good in the situation. And then you look at what are the responses of the patient. So basically the blue's all good, and the other one, the red's not so good, but you always get some dissatisfaction, which is good because you get feedback about how to improve that from that point of view. And as you can see, that most people are satisfied or very satisfied with lots of aspects of care. So FamCare is all these questions. And then bereaved carers' responses are pretty similar in terms of very satisfied. And one of the other things, I don't know if people have done this in their own area, one of the other things that we got asked to do by Bupa was to look at NPS, which is Net Promoter Score, which is this scoring system, 0 to 10 or 0 to 100, however you want to do it, where I think we all get this. If you go and get anything done, so if you get your car serviced or you go somewhere or buy something, they say, you often have to fill out a Net Promoter Score afterwards or asked to fill it out. So this is around things like how would you rate your time dealing with on this program? But the Net Promoter Score is on a scale 0 to 10 or 0 to 100. How likely are you to recommend this service to someone else? And if you get, I think it's 8, 9, 10, that's counted as positive. If you get something like, I can't remember the numbers there, I think it's 4 to 7, that means nothing. And if you get 0, 1 or 2, I think it might be 3, I have to get again, but you actually get that that's a detractor. And so the scoring system is the promoters, which are in green, minus the detractors, which are in red, and you end up getting a certain score. So some areas, and it's very common outside healthcare, and in healthcare it's common as such. So 68% Net Promoter Score is very high for a private health insurer. So they think this is fantastic as a thing. So these things make me think about, how does our funding or how does our model of care drive outcomes? And it makes me think a bit about like, why do different community palliative care service, or why are they all slightly different? And so at one stage, we've had, we've got 3 different models essentially running at the same time in parallel because of funding, and you have sometimes, in fact, funding is what drives somewhat the model. Interestingly, we have changed, in conjunction with Medibank, we've changed now to a fee-for-service model because we personally think that's the best model. That's something to discuss. Just to think at capitation, what capitation means is that you get a set amount of money, so it's a very American term, for a delivery of healthcare service. So, for example, when a patient came onto our program, we got a set fee for that. It was half the overall fee. When a patient died on our program, we got the other half of the fee, and that was a set amount. So no matter how long the patient was on our program, or how short or how long, we got the same amount of money from Medibank. Bupa funding, on the other hand, and that's somewhat similar in reality to publicly funded models, which aren't individually capitated, but overall, they say we're giving you this amount of money for the year, and you have to reach these targets, which I think most people reach. But then then it's not individually driven. So they say this is how much money you get overall, and commonly they won't say to you, this is how many patients you have to look after. They'll talk about occasions of service or activity. So that's another form of capitation, which people don't call it capitation, because capitation has this bad terminology because it's a very American term, but it's the same thing. And then fee for service, for say Bupa, is where it doesn't matter how long the patient stays on our program, short, long, or whatever, they still keep paying every activity we do with the patient. And interestingly, in a fee-for-service model, and a couple of reasons why we like that the best. One is that it means that we can see people. We personally think that it's an integrated care model in the sense that we see people who are getting ongoing oncological treatments or other disease-modifying treatments at the time, and sometimes they get really good responses and they go off our program, and sometimes they come on the program, but generally they stay on the program. And you get much more ability to share care of these patients over time. And interestingly, it ends up meaning that they're much more likely to come into a palliative care inpatient unit than they are to go back to an acute hospital as such. So I think funding really drives outcome measures. There's quite a high home death rate with all programs, but you can drive it if you want to get a high home death rate. You just be very selective from that. And I'm not sure that's really good. It just means you're selective. I was really surprised personally when we did all this, how much initially there were changes between patients' preferred place of death in different models. That seemed a very random thing. The importance of what's called our intensive program, and that really means just having an assistant and nursing available for these shifts between 3 to 12 hours close to the end of life to support people at the time. This preferred place of death, which someone asked me, was preferred place of death identified on admission or during the later stage of care? So it was identified at both times, and we've actually done a publication on this. The actual preferred place of death reported in here is the last preferred place of death of the patient. Now, I have come to realize preferred place of death is a very rubbery figure in the sense that it's not clear to me that the patient preferred place of death is actually what's important. In many ways, it's the carer's preferred place of death. So we would see a patient would have a preferred place of death at home, and that meant very little unless the carer supported that, because what would happen sometimes is the patient would get to the end of life, become unconscious, and the carer would not want to look after them at home, and they would be admitted to a hospital because they wouldn't look after them at home. So the patient's preferred place of death was home, but the carer's preferred place of death wasn't at home. So there's this thing around congruence around this. The other thing is this broader effect on a program. So, people often, when you're in palliative care, people can feel uncomfortable about the fact that, you're running 3 different models. People are getting different things on these different models. Is there discrimination? There's not actually discrimination. You'll just have the ability to give more stuff to some people than other people. where you would like to give it all as much to everyone. And in reality, the only way to do that is to actually show by evidence what is the best model and have that model funded on a broader basis. So for us, where we work, because we do both public and private, we can go to private health insurers and say, we think this is the best model. We want you to fund this via this model. And they're willing to do this because you have evidence. Fascinatingly, so from Queensland, despite this being about the only evidence around community palliative care and outcome measures and models, Queensland Health doesn't actually go and fund it on basis of that. They just go to HHS and say, here's your money, deal with it what you like. And people within that HHS just decide based upon that. Like there's no actual sort of, I don't think there's any looking at evidence and saying, this is how we should do a model, for example. So, and the broader effect on the program. So one of the things, early on when you bring this up is that people say, why should one people get it and not other people, which is very true. But I would like for everyone to have the same things in this. And I think the only way to show that is to actually two things. One is to show evidence, as I said. The other thing is that as we found out as time went on, and you have a broader sort of things that make the biggest difference. So things like getting an AIN available, we were able to sort of change parameters and fund that in the public program to some extent. And then it makes you think about what actually makes a difference in the end. Is it driven by patient and carer preferences, or is it driven by what the model does to start with around that? So I've probably gone a bit over, but I'm happy to answer questions. And so yeah, I'm happy to answer questions if they put in the chat, but just I've answered the gone. But okay. So may I know how the patient's relatives bear the medical insurance costs after exhausted? So there's no exhaustion of costs. So everyone pays their Bupa funding, and there's no exhaustion of costs. It's free. So Bupa just keeps funding it as long as they're on the program, as such. Now, interestingly, I could go into this whole costing of it, and we've got a huge amount on costs. The amount that Bupa pays per patient on our palliative care privately insured community program essentially has been the same for 7 years. So one of the concerns of private insurers on a fee-for-service model, and the reason why they do this capitation model, if that's the term I use, but not the best term, is that the capitation is they cap the fee. They have their risk is only that amount. The fee-for-service model is people are worried about basically over-servicing and, people, costing lots of money. And it turns out that our figures for our service would be that Bupa costs per patient haven't changed in the whole 7 years. Next one said, I've been reading the preferred place of death is most accurate in the terminal phase. Is that reflected in this research? I'm not sure what you mean by most accurate, which is really tricky because I think there's preferred place of death at the beginning and preferred place of death at the end. And we actually looked at, not necessarily just on this, but on overall, that most people don't change their preferred place of death, but some people change it a lot. And some people, some people change a lot, some people change it a few times. Most commonly though, majority of people don't change their preferred place of death, but it is hard to know, what does preferred place of death mean? Like, for example, if someone's at home and they say, I want to die at home, but then things are changing and the family says, I can't look after you anymore, and the patient acquiesces to that, are they saying, and they agree to come into a palliative care unit, are they saying my preferred place of death is inpatient unit now? Or are they saying not? The carer is certainly saying something. So I think I just think it's a rubbery figure, to be honest. It's a rubbery figure, which it's subjective. We need to see it as subjective in research. Home death rate is an objective figure. And I think that, I'm not saying it's manipulated, but preferred place of death is a more rubbery figure than a home death rate. Again, I'm not saying a home death rate should be really high because that doesn't reflect everything. But I think that we all have to understand that when people start talking about people dying in the preferred place of death, it's a rubbery figure. It's not as accurate as a home death rate.
Can I chip in too, Philip?
Yes.
You want to stop sharing and then we can have sort of a broader conversation. And thanks everyone for all the chat. It's going wild. It's great. I think that, obviously what you prefer is influenced by what you see as well, and if you feel like you may not have all that much support, or you have lots of support, then that will influence what you would prefer. So it's not like it's a true for all time, or, you know, a deeply held value statement only. It might well be, you know, profoundly environmental. So do you want me to manage the chat for you? Because it is going.
I can see that. I can see, Beth asked, do you have any ideas about how to better capture patient and carer preferences re-side of death? You know, one of the things that in reflection I would do would be, we do capture it somewhat. So we use this program called Palliative, which some people use, which does put in patient, I think it puts in patient preferred place of death. I'm not sure if it's carers. And I think in retrospect and reflection, I think it's really valuable to include carers preferred place of death in a separate question away from the patient, what's there, and to see what the congruence is. I don't know. I don't know if people have done that much, and then how that changes over time. And it's very hard to see. It's very hard to see to preferred place of death accurately recording it over time. I think is very hard. So I think I don't know if anyone uses Palcare. As a question there, sure, I've asked them every 5 minutes. On Palcare, it actually, when you log into Palcare to change anything, you actually technically have to answer that question every 5 minutes when you actually put it in, but it's not asked every time. But I think at certain points of changes, you know, when people come into hospital, it would be valuable to ask them, has their preferred place of death changed or not? They might say, my preferred place of death is not here, it's at home.
Philip, Dr. Das has asked who bears the cost of medical insurance, and particularly, I guess you've answered this perhaps, you know, that can it run out or does it get exhausted?
No, so the cost is all borne by the private insurer. So there's no cost to the patients in any of this, which is another thing why patients like it and insurers like it, because there's no out-of-pocket expenses, which if you're involved in anything to do with private care, that is the thing that people hate the most.
And that includes medications and ongoing anti-cancer treatment.
Well,
part of like the US hospice model, that's all wrapped up in the one sort of capitation, if you like.
No, this is all just palliative care. So if they're getting oncology treatments, that's completely separate. They have to pay that as I normally would do. Inpatient, if they come into the inpatient unit, then they would have to pay their co-payment if they normally pay a co-payment. So but at home, medications, interestingly, so it's Medicare provided medications. So it's PBS medications. So they do have to pay for that as they would normally pay for that. There are some medications we can provide if needed, but that's no different to our public program. That's Medicare provided medications. We don't provide PBS, sorry. We don't pay for medications in the community on our service. That comes from PBS medication. So for them, there is a co-payment around that if needed. Yeah.
And you mentioned a penalty if they were admitted to hospital.
Yes.
And who bears that penalty? Is that
St. Vincent's, yeah. So the community team, so ironically, the community, that's gone now, thank goodness. Ironically, the community team bears that. They don't bear it, they just get a certain amount less per night that the patient stayed in. It was just a ridiculous thing that people put in to start with. And if you ever are involved in negotiations, you acquiesce in the end to something to get things through.
And that was going to be my other question is, does it create a whole lot of complexity when someone's admitted to the program, trying to work out where they should be, or is that all fairly straightforward?
The complexity now is the fact that we don't cover every private insurer as such. So sometimes they're admitted. So if someone had different insurance and they came onto our program, technically they would go into the public program because there's no private insurance for that program in the community as such. So I think the complexity, so the public model, not too much complexity because it's just to be honest, it's a capitation model, but it's a broad model. So there's no there is payments involved and occasion service put in for that. Bupa and Medibank and now NIB and soon to be DVA essentially now have very similar fee-for-service item numbers with slightly different amounts. So we've tried to make that more consistent. It was a nightmare, to be honest, not so much for me, but for admin people and people managing the program for the nurse unit manager, because it was a different models as such. And the reason we went from the reason, so we would get less money per patient on the Medibank model on a fee-for-service model than we would on a capitation model, but we would be able to bring many more patients on who could get it, and also we could see them earlier and provide what we think is better palliative care, which is integrated palliative care into any disease-modifying treatment.
Which is a real strength in being able to do that within the private system, because that's not always possible. Indeed, it's not always possible in lots of ways. Sorry, you're going to add something.
Oh, just the other thing about that, and we probably haven't drawn that out so much in our research, is that what actually came out of this more than anything was that it really increased the admissions to our palliative care unit from privately insured patients under this model. And that wasn't anything we were trying to drive, and that was never anything financially the outcome measure. It was that being involved with people earlier meant that people were happy as time went on to look at a palliative care admission rather than an acute hospital admission. Not having an emergency department and having direct admission for appropriate people really like that. They were just never aware of that. So everyone's preference would be to direct admission to the palliative care unit for appropriate people. And so being involved earlier meant that those people had that option earlier. And so from a financial point of view, that was actually the biggest benefit to our service, despite the fact that we were trying to look at improved community, which is really interesting to me.
So it's clearly been highly successful, and interesting that, you know, that that they're continuing, and that B, you know, there are more private health funds sort of being interested in this model. So excuse me, congratulations, Philip. That's really great to hear work. There's been one last question, and then
David asked about stratifying for people who are compare your service fees. We didn't do that. The trouble, the trouble with FamCare is that it was so highly satisfied and very satisfied that it was very hard to get distinguishing between any. And so I know I've got satisfied and very satisfied in separate light blue, dark blue, but in reality, we just put them together into satisfied. And it turns out, you know, 95% of people or 96% of people are satisfied or very satisfied, and whether you're in hospital or at home. So it was very hard to know the difference between that. And from that point of view, so it was so we really didn't get teasing out that sort of stuff about like any higher satisfaction, because satisfaction was very high anyway. Interestingly, people still made all these comments about inpatient care in the satisfaction survey, despite it being about community. It was like, you know, I didn't like the food, you know, I didn't like the visiting hours or something, you know, something about, you know, it's hard to get park. And so we eventually have tried to stratify that away from inpatient and community. So I think you probably need to have more discriminating satisfaction surveys or something else about that to try and really work out, is there a difference between people who die at home and hospital?
So it wasn't that their partner was a bad cook, it was...
No, the cooking was in hospital food. So in hospital food, so they were not happy with that, yeah.
So it's come to the end of the time. So thank you, Philip, for a terrific presentation and for managing the chat with such alacrity. I have learned a lot, and I really commend you for getting involved in this space, because I think we're sometimes a bit sort of nervous about thinking about the whole, you know, how the whole private system can work for palliative care, and you've really demonstrated some great opportunities. And we're all very worried now about our NPS score, and we've heard also about AI and drawing, which I've never seen before. So thank you very much. And I ask the audience to thank Philip for his presentation. I also wanted to thank the team behind today. So most specifically Stacey, and particularly Tanya, who organises these events and makes it all happen so smoothly, and we all know what to do, and it's wonderful. And for those who may have wanted to be here, if you've got colleagues, it will be up on the website in a couple of weeks. And finally, thank you to you, the audience, for coming along and for having such a stimulating chat and getting involved. It's really been terrific, and we look forward to welcoming you to the next one, which will be in August. And that will actually be, we're looking to launch the Care Plus implementation package for early palliative care. So we would welcome you all to come along to that, and have a good evening, everybody.